Wiley, would you like to go ahead and get us kicked off for today's webinar?
Absolutely. Thank you, Alana. Hello, everybody. Good afternoon. Welcome to this webinar focused on immigrants, refugee, and Asylee populations. I am Wiley Liu. I'm the Executive Director for the Center for Community Engagement here at UCSF. We are very, very lucky and happy to be collaborating with the Latinx Center of Excellence to bring you this webinar. I have to warn you, my Wi-Fi is not very stable, but I hope you can still hear me. We have a very distinguished list of panelists for you this afternoon. Dr. Alicia Fernandez, Dr. Adrian Aguilera, Dr. Raul Gutierrez. I am so sorry if I'm not pronouncing your names correctly. Ms. Amelia Martina Banghead and Dr. Lydia Liang. So they will introduce themselves more fully with you when they start their presentation. So Alicia, I think we're starting with Dr. Lydia Liang because she might have to leave a bit early.
Thank you, Wiley.
Take it away.
Yeah, and I just wanted to provide a couple quick updates just before we get started with the session. For all attendees, you should know that you're in listen-only mode. We encourage you, unfortunately, we're not going to be able to open up the lines for the webinar. So please make sure to utilize that question panel where you can go ahead and enter your questions. We'll be monitoring that information throughout the presentation, and we'll be reading those off as we enter into the Q&A session. This webinar will be recorded, and we'll also be posting the recorded webinar on the Latinx website. The address is there below. Again, we're going to keep very brief presentations by all of our panelists with a hope to reserve about 30 minutes for Q&A at the end of the session. And again, we apologize for not being able to open up the line, but please make sure to enter in your questions into the question box. If we're unable to get to your question, we will follow up with you after the webinar has concluded. And so with that, I will turn it over to Lydia.
Thank you, Alana.
Thank you, Alana.
Hi, everyone. Good afternoon. I'm Dr. Lydia Liang. I am a family doctor from the Department of Family and Community Medicine at UCSF, and I am based out of San Francisco General Hospital. So for the next few minutes, I'm going to spend some time talking to you about outreach efforts as well as the rising xenophobia and racism in San Francisco and in kind of wider in the nation as well. So I will just start by saying that in late January and February, I, along with other Cantonese and Mandarin speaking providers in collaboration with the San Francisco Department of Public Health, did very early outreach to the Chinese community who live in Chinatown and in the wider Chinese community because they have been hearing about the coronavirus outbreak starting in Wuhan, China. And so many of us at that time were focused our messaging on based on CDC guidelines and recommendations. So all of our messaging was centered around recent travel to Wuhan and mainland China, as well as direct contact with anyone who is known to have the COVID disease. I will say at that time, the language was still starting to evolve around what to name the disease. We attended a number of town halls in public schools with family members who were monolingual, speaking Cantonese and Mandarin. We had meetings with community and business leaders to talk about what the impact of the coronavirus would be on the local community. And then with public health information, we were trying to disseminate with local Chinese newspapers, radio stations, and TV news channels. And a number of us went to table at the Lunar New Year parade this year, which was much more sparsely attended compared to years past. As we were seeing already in very early February, the rising xenophobia was already seeing an economic downturn in Chinatown, San Francisco, much earlier than we were seeing in the rest of San Francisco, because Chinatown was very dependent on tourists for their businesses. Next slide. And then in March, with the shelter-in-place order and us learning a lot more about community transmission worldwide, we had to shift our focus completely to a different arm. We went from going out into the community to doing a lot of individual outreach. So I will say for myself, as a family doctor, I take care of multi-generational families who often live in the same homes. And so what I'm going to talk about is really through the lens of someone who takes care of a lot of families. And I myself take care of a predominantly AAPI and actually Spanish, monolingual Spanish-speaking community here at the General. So when I would speak to the elderly patients, I am very keenly attuned to whether there's elder abuse actually happening in the home. There's a lot of pressure cooker situations right now with the sheltering in place order, with people living in close quarters. I'm talking to my patients about, you know, who is helping them get meals, how are they getting their essential needs met, and then making sure that they are staying at home as much as possible and reduce their risk. But also realizing that there are people who are going to come into their home if they stay at home. So thinking through with them, how do we reduce those risks of folks who are coming into their home? And then when I talk to my patients who are working adults in the AAPI community, many of them work in service industries such as restaurants. And what I have seen with patients of mine is that, you know, when you work in restaurants, you're really dependent on tips for the bulk of your income. And so many of them have taken a hit in their income. And then as many of us know already, many people also are, you know, especially if they work in non-essential service industries, no longer even have the ability to be employed. And so some of my conversations is, how do you fill out unemployment applications for patients, especially when they can't come out to you, where to the traditional model is I can help my patients with the behavioral health team fill out forms. And for my Chinese speaking patients, the form is not even available in any Chinese language. So there is a line that they have to call in order to get that help. So a lot of navigational tools to provide for them. And then one thing I want to highlight is just those who live in single room occupancy and other congregate areas. This was an early concern in the Chinese community and the AAPI community. I don't know that many know about the fact that many of them actually live in these settings. And fortunately in San Francisco, we do have isolation and quarantine centers now for those who are testing positive. But what I have heard from those who have been on the ground working is that many of the Chinese and AAPI community members who are being placed in these quarantine centers are feeling deeply isolated because there's actually no language concordant folks who are working on those sites. Next slide, please. And then lastly, I just want to raise a point of xenophobia and racism. Back in March 19th, a reporting center was launched called Stop AAPI Hate. And over a matter of 2 weeks, they received over 1,100 reports and this is a crowdsourcing kind of website. And you will see that most of it is verbal harassment. And as we move into shelter in place, a lot of people are getting harassed, mostly in places of businesses that are still opened. And I will say, you know, as I've been hearing some of the virtual town halls in San Francisco, the San Francisco Police Department continues to say that there has been no rise in hate crimes in San Francisco, but I don't think it's telling the whole story because really the numbers are as good as what's being reported. So I'm going to stop there and move on to the next guest. And if there are any questions, the next slide you'll see I provided my contact information just in case I do have to hop off a little bit early today. Thank you.
Thank you.
Hi.
Please go ahead,
hello,
Dr.
Yes.
Raulutia.
Hello, everyone, and good afternoon. My name is Raul Gutierrez. I'm an associate professor in the Department of Pediatrics and also based at the San Francisco General, and co-direct a clinic called Bridges for recently immigrated children. Next slide, please. I'm going to talk a little bit about our experience in talking with families during this pandemic, particularly for recently arrived immigrant children and their families. This is a quote from a patient's father, which I think is very real across the country. I wanted to ask if an undocumented person has coronavirus, do they treat him like a normal patient? Or does he have, or does he not receive care for not having documents? My cousin's mother is afraid to go to the hospital there in New York, and I wanted to know if you have any idea how to do it. Next slide. So among the nearly 150,000 cases reported as of April 2nd, for which age was known, only about 2,500 or 1.7% occurred in patients aged less than 18 years. In comparison, persons aged more than 18 years account for 22%, persons aged less than 18 account for 22% of the US population. In California, this number is approximately 220 cases, or 1.3% of total cases. In San Francisco, only 1% of cases are children. 2 children have been diagnosed at Benioff Children's Hospital in Oakland and 1 case at Mission Bay. There have not been any pediatric cases at the General. And additionally, relatively few pediatric COVID-19 cases were hospitalized, consistent with previous reports that COVID-19 illness often has a mild course among children. 73% of children report the characteristic signs and symptoms of fever, cough, and shortness of breath, compared to 93% of adults. So a little bit of reassuring news in terms of children and their impact and the impact that coronavirus is having on them. However, we still have a lot more to learn about children and how they transmit the disease and what the risk is to other family members, especially since we're not really testing that much in children. Next slide. At the Bridges Clinic for Immigrant Children, again, we see recently arrived immigrant families anywhere from up to 3 years from their arrival. 66% of those children report some type of trauma, and about 92% require some intervention of those 66%. 90% are seeking asylum, half without legal representation, and as of April of last year, around 1 year ago, about 100% did not have any legal representation. We do have a team of family navigators that are reaching out to about 80 families, and the top needs have been housing, employment, legal access, childcare, and food. Next slide, please. So our family navigators, social workers, and providers have certainly been fielding many questions related to paying rent and eviction risk. Many have informal agreements with their landlords or master tenants, which makes it challenging to practice their tenant rights. Additionally, many are not aware of the eviction moratorium or the process for protecting themselves. Questions have also come up about how to isolate themselves when they're sick, especially when in multi-generation households or living in small spaces such as SROs, or living in one room of an apartment or a house. Next slide. I think there's an education one missing there, but distance learning has also been challenging, especially when no one at home speaks English. Kids have lost a tremendous amount of structure in their lives, particularly those with special healthcare needs that were provided in the school setting. Certainly schools are already thinking about enrollment for next year, which can be a challenging endeavor for newcomers not familiar with the system. From a national policy perspective, there have been court closures. So this is exacerbating the backlog in immigration court dates and delaying the pathway to citizenship and benefits for many of our families. Detention centers have been a focus of concern for rapid spread of illness, and border policy changes have changed a lot, which is very concerning for some of our families who were waiting for some of their family members. We know that there was a report today that Border Patrol is now returning unaccompanied children to their countries as well, and not allowing them to come in and for asylum as was done previously. Next slide. And so the response has been multifocal for us. We're improving our telehealth as much as possible, utilizing our family navigators, health advocates, and coaches for targeted outreach, centralizing a repository of resources, looking into inequities research, and really advocating on the education front. Next slide. And I will leave it there for our next speaker, and just a thank you to all of our community partners.
Thank you, Raul.
Dr.
That was
Gutierrez.
terrific. There's Alicia Fernandez, and I'll get started now. Next slide, please. This shows a number of hospitalizations in San Francisco, which right now are around 90 or 88. I want to start by giving you a big picture of what's happening medically in the city, and then I'll break down a little bit of what's happening in the Latino community. So about 88 hospitalizations, about half of them are, a little under half are in the ICU. Keep going. And then this is a complicated slide, and I want to talk you through it. You'll see on the left where it says 797 cases, 13 deaths. That's as of today. And that is cases who test positive. It doesn't say anything about the severity of illness. The gender breakdown is a little bit more male preponderant, as is being seen in other countries. And in the ICUs, it is definitely more male preponderant, as has been seen in other countries as well. You can see the age group breakdown here, a reminder that this is a breakdown of positive tests, not of severely ill people, and it's tilted younger. That may just show who is being tested in San Francisco, as opposed to it's a younger proportion of positive people than in other places. I'm going to go over the race ethnicity slide later, and then just to point out that here this large category represents community transmission, and then the small category of gray represents transmission from a known contact, which is to say that most of the people who are getting sick without knowingly coming into contact with someone who is infected with the virus responses for COVID. Next slide. So let me show you what this means in terms of the, this is the population in San Francisco, and this is the percent testing positive. And what this shows you is that Latinos about 24% of positive tests. I did this webinar a few days ago, and at that point, Latinos represented 20% of the positive tests. So this number is going up, and going up quite fast. As you can see, for other groups, it's for Asians and non-Hispanic whites, it's less than the proportion in the population. For African Americans, it is about the same. There continues to be about a third of tests for which we have no demographic information. And I know that the Department of Public Health is trying to improve that, but that remains something that folks are working on. Next slide, please. It is not surprising that Latinos constitute the largest proportion. Many places are reporting this, places as dispersed as New York City, where the proportion of Latinos is about twice that it is in whites. Parts of Boston, such as the community served from Chelsea in MGH, and Oregon and others. Here are the death data from Santa Clara County. So caveat, the total deaths is 47. It's hard to draw a lot of conclusions from 47 deaths, but nonetheless, there is a suggestion that there are more deaths among Latinos than among other folks with respect to their background proportion in the population. Next slide. So with what are we seeing at San Francisco General, where I also work? We are seeing overwhelmingly monolingual Spanish-speaking Latinos coming in to the hospital and to the ICU. These do not represent family clusters. They do seem to be people who are contracting the disease in the community. We are still in the city as a whole. We have 13% positive tests. To give you a background, in South Korea, it's 1% positive tests, and it's because we're not testing that much. If we were testing more people, the number of positive tests would go down. And I think that we are seriously under testing among people without doctors. and including many community members in vulnerable communities. And consequently, I suspect that these numbers will go up much more. Next slide. So if you want to follow the news, some advice, just the case, follow the case numbers judiciously. The number you really want to be looking at are the hospitalization numbers. I had this from before, that you can follow Dr. Bob Walker, Chair of Medicine, on Twitter. He posts the numbers at UCSF Health and San Francisco General, but it looks like San Francisco DPH is now posting those numbers every day on the San Francisco COVID tracker, so you can look there. Fortunately, the number of deaths in the city is still very small. I believe we're at 13 now. Next slide. Why do we have more? Why are we and others reporting increased COVID among Latinos? I think it's because of the twin epidemics of COVID and inequality. As you know, many people in the city is a crowded, highly dense place with many people in small spaces, particularly people who rent apartments or many people in a single room or houses. As you know, this is low-wage work. Many Latinos are low-wage workers, and people obviously need to continue to go to work. And then on top of that, many people work in essential industries where they're required to go to work. People still need to use public transportation, which is another way where people may get infected. It is highly difficult to isolate when folks develop symptoms if they don't have access to additional rooms and bathrooms. Food insecurity due to lost wages and no sick leave has many people out on food lines, and I am concerned that food lines themselves are a source of infection in the city. And then finally, it is difficult to get tested. As I said, if you don't have a doctor and are uninsured, but there is also a fear of getting tested, both for fear of the financial consequences and fear of immigration consequences. It's important for all of our CBO partners, everyone on the webinar, to know that ICE has said that they will not consider COVID testing or treatment in any public charge considerations. Nonetheless, for a lot of mixed status families, this continues to be a source of concern, as Dr. Gutierrez pointed out to us. Next slide. So what is our main message as physicians, and I hope as CBOs? If people have symptoms, get tested. That will help. And the ways you get tested is to call your doctor if you have a doctor. And if you don't have a doctor, call 311. And that will give you an appointment for get you an appointment for a test. And that is very helpful for people who have no doctor or for people who have no insurance. They will ask you some screening questions, but that's okay. And people should answer those screening questions and take those appointments. If you don't want to do the 311, or if that presents barriers, you can walk into San Francisco General. We now have a testing site set up at the old hospital, in the old hospital emergency room, that is special for people presenting with respiratory symptoms. And there, anyone can get tested. It doesn't matter what their financial status is or what their insurance status is. Next slide. Why are we arguing for testing? Because DPH is making available rooms in hotels for people who need rooms in order to safely isolate. So for people who have COVID and need isolation, DPH is making those rooms available. Even if you are able to stay at home, we can give you masks and things so that you can stay at home more safely. And finally, we are doing medical monitoring of people who are ill and are not sick enough to be in the hospital, but they're at home. We are calling those patients to make sure that they are not becoming more severely ill. Next slide. Very briefly, COVID in 2 slides. I think most people know this. In the incubation period, we think it's around 4 to 5 days, that it's a droplet-produced illness, and that the symptoms can range from none to respiratory failure. It is, we're not sure what proportion of the people have no symptoms at all. It may be much larger than the 80% that we are stating. Next slide. So right now, we think that about 80% have non-severe symptoms, meaning they can manage the disease at home. That ranges from no symptoms to symptoms of a bad flu. About 20% are in the hospital. Of those, about 5% are in the ICU, usually with respiratory failure. What does that mean? That they're unable to get in enough oxygen when they breathe on their own, and that's why they need ventilators. The symptoms are also, I think, well known at this point: fever, cough, shortness of breath. Myalgia means muscle aches, but we are also seeing diarrhea, sore throat, and even the occasional runny nose. In general, runny nose tends to argue that it isn't COVID. Next slide. Next slide. Oh, actually, this slide is to remind me to tell people that the time that we most worry about patients is in the second week of symptoms. The risk period is roughly between days 7 and 12, when people can get worse. Boris Johnson had been sick for 10 days when he went into the hospital. That's a classic presentation, right smack in the middle of the danger period, when people may need more support. And then just to remind us, even most people on ventilators will recover, but it will be hard and difficult. And most people who are ventilated do need 3 weeks of hospitalization as the norm. Next slide. I think the risk factors are also well known, and I won't go into them, except that if anyone needs one more reason to stop smoking, this is it. Next slide. I think people are aware how social distancing works and why it's important. Each one of us who is positive infects between 2 and 3 others on average, and can infect many more. So it's stopping that rate of transmission. Next slide. So again, our message is pretty straightforward. Stay at home if at all possible. Use a mask and physical distancing when outside. Wash hands with soap. Understand that physical distancing includes family members. Just because they're part of your family, if they live outside of your house, no, you can't go over to visit them. And that is an area where people in the community have been confused. Get tested either by calling 311 or your doctor, or coming to our hospital. Protect particularly the elderly people and vulnerable family members by keeping them away from children. Children are the group that is most likely to not have symptoms and yet still be shedding the virus. Next slide. Let me stop there and turn to my colleague, Dr. Adrian Aguilera. He is a clinical psychologist who sees patients with us at San Francisco General, and is a faculty member at UC Berkeley.
Yeah, thank you very much. So what I want to talk a little bit about are the mental health implications during this time. I think thinking broadly, so I'll get next slide, please. So just getting into it, some of the things that we want to consider during this time, I think we can all benefit from these things, but particularly when we're talking to folks in the community, patients, et cetera, is that it is a very stressful time. And it's important for us to remember to be kind to ourselves and each other. These are not normal times. So the expectations that we often have of ourselves, that others have of us, we may not be able to meet those expectations. That takes a variety of forms. So we may not be able to work. If we are working, we may not be able to work in the same way we have before. Caring for family is going to look different. So when such a big, in a lot of ways, this is a big intervention. When this comes at us, everyone's trying to figure out how to deal with this new reality. One of the things, although it can be challenging, and it's more challenging when you're in difficult situations, is to try to think about some things that that we can be grateful for on a regular basis. It's hard. We're bombarded by a lot of negative news coverage and challenges, economic difficulties, but hopefully we can find some minor, at the very least, positive aspects of each day. I think one thing, something that people are focusing on is being able to spend time with family, for example. Finding enjoyable activities despite limitations. So this is something that we often focus on a lot as when I'm doing work with patients. And one way to get out of feeling depressed is to engage in activities that are pleasant, that are meaningful. And this is hard to do when we're stuck at home. So thinking about ways that we can still meet some of these goals while being within our limitations. So this could mean some sort of hobby that one has left behind that you can still do at home, for example. The last thing is trying to connect with others. So that's something else that's extremely important for all of us as humans, and that's what's being impacted the most physically right now. So trying to think about how we can connect with others, be it by phone, by video. I think I work a lot with Latinx immigrants, and I think one of the, to some extent, our community is used to doing this via distance with family members in other countries and things like that. I think we have to apply these things a lot more during this time. Next slide. So some local resources, and all of these are bilingual. There's a California peer-run warm line that's local, and so this will connect you with with a peer, basically somebody else that's not a professional necessarily, somebody to kind of talk to during a difficult time. And this is available in both English and Spanish, at least. Not positive of other languages. And the SF suicide prevention line. I'm pretty sure that one is beyond Spanish and English. It's another resource if things are getting particularly serious. A couple other resources for parents as well. There's a San Francisco 24-hour crisis line for parents to get help. This is a challenging time for parents, having to not only juggle spending time with kids, with limited physical space, and also oftentimes juggling work and things like that. The parent line run by UCSF is another resource that's focused particularly on younger kids, aged up to 3 years old. And your doctor will end up being a connection. So the work that I do within behavioral health at the General, we see our folks based on referrals from doctors. And in terms of behavioral health services, mental health services, we're trying to adapt to this kind of new reality since we're used to seeing folks face to face. And we're trying to implement some telehealth, but that can also be a challenge because people have limitations in terms of their digital literacy. Next slide. One of the areas of my research is doing digital health intervention. So working with apps and messaging and things like that. So this is a time where we might be able to utilize these resources as a way to deal with some of these challenges with our emotional health. So I've listed a few that are available in both English and Spanish at least. So Headspace, Calm, and Siente. So those are 3 apps that focus on mindfulness meditation. So taking a few minutes out of your day to just kind of reset a little bit emotionally. Activate or Activate is an app focused on activities that one can do. So some of these, are things that we can still do in this time. Some might not be. Sambello is a stress management application that has a variety of tools within it. And then a couple other resources. 7 Cups of Tea is a way to connect with other folks. It's kind of like the peer line, but online. Support Group Central. And then the last link is some meditation recordings. My group is developing a texting program to send messages related to dealing with mental health during this time of COVID, and we should have that ready at some point next week. So we'll share that with folks. Alana, is there another slide I forget? I think that's it. Yep. Thank you.
Thank you, Dr. Gutierrez. Amelia, are you ready?
Yes. Hi. Hello, everyone. My name is Amelia Martinez-Bankhead. I'm the Director of Community Engagement with the San Francisco Human Rights Commission. And I just going to share a little bit about what the Emergency Operations Center is. Some of you may have been hearing the term EOC thrown out a lot. And EOC is the Emergency Operations Center, which is activated every time that there is an emergency within the city and county. And what it is a number of different agencies from the city come together to work on a plan to make sure that everything that is needed within the communities is being put in place. It pretty much becomes a hub for the city. At the moment, they are right now at Moscone Center. And if we could go to the next slide, sorry. The next one, the next slide after, yeah. And just so that folks are aware, because we have been, and a part of the work that I currently do is talking to a lot of the different community organizations and stakeholders within the Latino community, particularly within the Mission District and also other districts such as Bayview, Excelsior, Potrero Hill. We want to really make sure that the work that's being done is being done through and using an equity lens, making sure that materials in particular, getting the message out to all of the community is being done in a way that resonates within the community. And in order to do that, there's been a team that's been put in place. And as you can see in the slide right now, there is an equity team that works directly within the management team. This is just to make sure that any of the information that does come in, the needs that are requested in terms of language, they are put into effect as fast as possible. Of course, with things changing so fast, we're trying to go as fast as we can. And then we have an operations team and a community branch. And what that means is that there's a lot of folks that do go out into the community at this point in time, trying to get the message out, especially to those areas where there has been reports of large groups congregating. For example, I know there has been word that in the Mission corridor at some of the markets, we are still seeing some folks congregating, and just making sure that we are focusing the attention to work with the small business owners, also letting people that we still see on the streets know about social distancing, what that looks like, right? It's not just that, you know, being a little bit separated, it's mentioning the whole 6 feet, now wearing also a mask. Making sure that that message is being put out there. There are materials that are constantly being updated, and a number of resources that are available for the community in several languages. So the equity team also has members that speak different languages, Spanish, Chinese, Tagalog. We do also have ASL. We're very mindful of everything that we do, making sure that everybody can understand and receive the message that we're trying to send. Next slide, please. And this already probably is going to cover a little bit of what I've just mentioned, but we're also trying again to make sure that we keep an ear out on the streets and just making sure that whatever we see that is a potential issue, that we flag it to the pertinent department within the city and make sure to make recommendations so that they can work off that. We also, in the process, have been working with a lot of task forces that have been coming up as the days go by. There's been a lot of community groups, so we're making sure that we're working with all of them too, making sure that we have community as part of the process as we go, as knowing that that is very important to be able to get the message, especially making sure that the message is being received by folks that are also known within community. Next slide, please. In terms of resources and printed materials. Printed materials have been one of the biggest things that we've received as an ask, and that we're trying to make sure that we get out there that are simple, that are easy for everybody to understand, and so that they can either post them in their buildings, post them in businesses. In terms of language, we've also making sure that not just having it, for example, in Spanish, that we have also materials that are in the Mayan languages, which is also a big sector of the population within the Mission District that many times can be monolingual. So making sure that we work with partners within the community that can provide that information so that everybody can get what they need. At this moment, you can see the links that are provided there. If you go in, there's a toolkit that will have information in several languages that can be printed. There are videos also available. We also have been working on creating webinars so that we can reach out to specific communities. We are looking at doing some of these webinars also in other languages. We will be doing for sure, one of the first will be in Spanish so that we can reach community members. We'll be doing this twice a week, again, because we know that the information is ever changing. So we're making sure that we can give up-to-date information in that. For those organizations that would like to get some printed materials, materials are available at the EOC. And as you can see there, you would have to go to the Moscone Center South. They are available 9 to 5 there to get materials. Also, if we go to the next slide, has my contact information. If anybody has any concerns or anything that they would like to share, any questions in regards to the EOC, please feel free to reach out to me. If there's anything also in terms of materials and maybe language, any languages that are missing, we really want to hear what is out there that is still needed so that we can help provide that. So please feel free to reach out to me with that and any questions that you may have. Thank you.
Okay, why don't we start taking some questions of, and thank you, Amelia Martinez Bankhead. That was very useful to get a sense of the city's equity work. And why don't we start taking some questions from the webinar audience and see where we are, because we do want to make this as much of a dialogue within possible.
Sure. Hi, my name is Julia Farfan. I'm a research analyst with the Latinx Center of Excellence. And I'll go ahead and start our question and answer portion. A lot of folks are wondering if we are recording the webinar, if it'll be available. I just went ahead and sent the link to the webinar recordings, and I'll also go ahead and post a link that has many of the resources that were talked about today and more also in the chat. So there they both are. So our first question is, can a person be infected by the SARS-CoV-2 twice?
I'll take that. I think, and I think the answer to that is we don't know, but we don't think so. Another way that that question frequently gets asked is, if I already had it and I tested positive, am I going to get it again? And it appears that no, that people are not going to get it again because, or that it would be very rare because the indications out of China, the studies out of China are showing that people do not get reinfected.
Great, thank you, Alicia. Our next question is that it looks like, would anybody be able to speak about COVID being transmitted in an aerosolized way?
Lydia, do you want to take that or do you want me to?
You can go ahead.
So we do think that I'm not sure what is behind the question. So let me answer it in two ways. Can COVID be aerosolized? Can the virus that causes COVID, the SARS-CoV-2, can it be aerosolized and can people get transmitted? Yes. That is why when we do, for example, procedures in the ICU or in other places where we do a procedure that aerosolizes the virus, like intubating someone, it is so important for healthcare workers to be fully protected using the N95 masks. So yes, it can be aerosolized. The second part of this question is it often aerosolized, or can I catch it from the air? No, we don't think so. We think that while in general, almost the transmission is mainly based on droplets, and droplets don't travel very far, and it's not as though the virus is in the air like other viruses are, like say chickenpox, that is a respiratory virus. I hope that is clear. Please keep going, Julia.
Great. This one has to do with language disconcordance rather. How can we track how language disconcordance is affecting quality of care for limited English proficiency patients?
I think all of us on this panel are very interested in that question, and we're interested in many ways. How is it a barrier to access to healthcare? And then, as the questioner suggests, how does it influence questions? So let me say, I do think the city has done a very good job at staffing up 311, and I believe that there are many languages available. Nonetheless, I worry about people who speak less common languages. And I do think, as an aside, that we should need to drop even further the barrier to testing and have walk-up testing throughout the city, particularly in communities particularly in immigrant communities, where trying to navigate the whole issue of do you have insurance can be frightening, as well as everything else. But leaving that aside, the second question is, how does language concordance affect the care? I think it is even harder when you're hospitalized and sick to not speak the language, or not have nurses, doctors, respiratory technicians, other people who don't speak your language. I think it makes a frightening, isolating experience much worse. And yesterday I saw patients. I did a telephone visit with, most of my patients are Spanish speaking, no problem. But yesterday I also did a telephone visit with a Vietnamese speaking patient, for which I use an interpreter. It is very hard to use interpreters well on the phone. It adds yet another dimension of difficulty. So we will be looking at that from a research perspective. And let me invite the other clinicians or anyone to say if they want to add anything.
Yeah, I will add, so at the Family Health Center, we have operationalized it and made it an option because most of our providers speak another language other than English. So we have sorted some of our patient panels by language so that hopefully they actually have a language concordant provider calling them, because as Alicia is saying, when you use an interpreter, so much is lost, especially when you don't see someone's body language. And I will just speak for myself. When I was doing a lot of the outreach, even in the Chinese community, the word quarantine and isolation is being translated exactly the same in other languages, even though they have very different meanings. So it's really important sometimes to have speakers who have that fluency in the native language of the patient to understand the nuances.
Next question.
We have actually a handful of questions coming in about folks wanting to know how they can be of use and how they can help the community. Specifically, medical students, what can they do to help in this time? And also how do bilingual providers get redirected to facilitating those interactions with limited English proficiency patients?
I'm not sure I fully understood the second part, but medical students, we are asking at the Latinx Center of Excellence, we are asking medical students to come and volunteer. We will be sending students out to do some teaching and leafleting on the food lines. So please get in touch with us. We are asking students to come and volunteer. I didn't quite understand the second part of the question.
My apologies. The second question is, are there opportunities for bilingual providers to be redirected to facilitating the screening of LEP patients?
I'm not sure what the person is asking. Does anyone understand? Maybe the person could be encouraged to rewrite the question. I'm sorry. But if you're saying, are there bilingual providers who can provide more care? Well, there is what Family Health Centers is doing, like Dr. Leung explained. They're sort of resorting their patients during this time of emergency. And that is one thing. If the question is, how can bilingual providers help? I think that that is a great question, and I don't know the answer to that right now. But I do think that if people are bilingual providers and want to volunteer, particularly to step up for peer lines, like the mental health peer lines, this is such a hard time for our community. And I think that what Dr. Aguilera was talking about, those peer lines, that would be a great place to help. I also think that there are going to be more opportunities for people to volunteer with the city for food services and other services as this goes on. Go ahead, Julia.
We have a question coming in about the use of antibiotics for COVID, and sort of wondering if there are materials available in other language that helps give basic science information, differences between viruses and bacteria.
I'm sure there are information. One question that I had for Dr. Leong is that I have heard informally that many Chinese folks here are getting a lot of excellent information from China on WeChat and other apps, so that they can get information in the different Chinese languages about the treatment of COVID and COVID symptoms. What I do want to say to everyone here listening is that unfortunately we have no antibiotics for COVID. There is no yet, we don't know yet of any antiviral that has been shown to be effective toward COVID. Dr. Young, can you comment on, Lydia, can you comment on whether or not folks in the community are getting good information from China?
Yeah, I would say that some people are, and then there's a lot of really, I think, inappropriate and fake stuff circulating. So I have actually been really proactive in asking my patients when I talk to them what they're seeing and hearing through their own communities, because it's a really good touch point to hopefully give the right information when I'm on the phone with them. There are some really, I think, really scary things that are being shared on those channels, but I also know that folks who actually know health providers in China are getting really good information, because they almost get a handbook on how to get the treatment. And then in terms of kind of I would say public-facing information, WHO actually has a really great Mythbuster page. I don't see that it has been translated to other languages, but I have been using that because it has one of the most common list of questions that people ask over and over again, and they explain it in a really, really succinct way.
Excellent.
Yeah.
More questions?
Sorry, this is Raul. I just wanted to add to that comment a little bit, and to just be aware that information is being shared in many different ways and different platforms, not only locally, but nationally and internationally, with different types of immigrant populations. And so information that might be shared here could get to someone across the world. With different platforms of communication. So really being aware and how we ask our questions and saying, what do you understand about what's happening right now? What are things that you have tried at home, to really get at some of those things and those myths and that misinformation, to correct it as much as possible. And the other thing that I wanted to say was with those rare languages, from mom, for example, sometimes we do have to think about alternative ways of getting the information out there. So using video, podcast, or something like that, where legible or written language isn't necessarily the main way of getting information to patients in the community.
Mm-hmm.
Yeah, and hi, and I just wanted to add too that as I had mentioned earlier, that's why we're looking at having webinars that are going to be focusing on debunking myths, because we've been hearing a lot of that, and we just want to, in any way possible, help kind of what do you call it? Kind of break the cycle of the myths that have been going by and just debunk those. So that's something that will be coming up in the next couple of weeks through the city and county.
More questions?
Great, thank you. We have many folks who are concerned about the upcoming Easter holiday, people wanting to spend time with their families. What is your recommendation of how to speak to family or friends that really aren't taking the quarantine seriously?
Adrienne, do you want to take that?
I think this is obviously challenging. I think tapping into folks' motivation. I think thinking about, I think about immigrants, for example, and the family closeness, right? And that's why people want to get together. But I would just try to use that same motivation for trying to stay apart. Because you love your family, you're doing something that's even harder than, that's harder to do because you love them. So obviously you want to be with them, and that's it's a value, but you can use that same value by trying to protect them. So I think this idea of protecting your family, I think maybe one way that might resonate with folks, because that's why they want to do it. So I think the first thing is acknowledging the reasons why, right? I think if we just dismiss people and say, don't do that, that's so bad, people aren't going to listen. I think if we acknowledge, yes, this is really challenging, we all want to be with our families, you want to be with your family, but think about the consequences.
Right.
Nice.
I also want to acknowledge from a pediatric perspective that, there is a certain amount of cultural wealth that is being lost in not being able to engage in some of these traditions and some of these kind of more cultural activities. And this can be really confusing for kids. And so having that conversation as well with children and helping them understand, what is happening and why we're doing this and the meaning behind it, but also finding alternative ways to think about how we can continue, or communities continue to share that cultural wealth that's really important for kids in particular in terms of their development and their self-esteem and kind of moving forward, especially in as Lydia was saying, in times when people are really turning to racism or xenophobia for certain communities.
Do we have time for another question, Julia?
Yes. What are we doing as UCSF and Bay Area physicians to advocate for the decarceration of immigrant detention centers and to ensure that all immigrants are covered in the COVID packages, not just state and federal level?
Raul, do you want to talk a little bit about it?
Yeah, absolutely. There's a big push on different fronts for the release of children in shelters and family detention centers, as well as adults in detention centers across the country. There are a couple of court cases that are specific to that. There have been several professional medical organizations that have signed on to these affidavits to these court cases. The American Academy of Pediatrics has been at the forefront, particularly for children in detention centers and shelters, and trying to release them. There are several grassroots medical organizations that are also writing petitions and really trying to put pressure on our congresspeople at the state level and at the national level for the release of folks from detention centers and shelters. I can't tell you specifically what UCSF is doing. There have been some advocacy on other fronts, but certainly there are a lot of medical providers who are advocating for the release.
One more question?
Sure. This one has to do with, dissemination of correct COVID materials. One of the panelists spoke about UCSF and physician engagement in Chinese media, but is UCSF doing other media outreach, and does UCSF have other media presence in other non-English media?
I can answer part of that because in the last week or so, we have really stepped up our efforts to engage with Spanish-speaking media, and we're doing that in partnership with the Department of Public Health and in partnership with community-based organizations. And I think we've done a lot more in the last week or so, and that's really, I think, making a difference. I'm hearing from a lot of people, oh, we heard about that, we know about that, I saw you on TV. So I don't know what all is being done in other languages. And I do think that it may represent something that we need to be thinking about for others. However, UCSF has been very prominent on Channel 26, which is for the Chinese community, and has been doing some good work there. And now we're making more strides with Spanish. So that's something. We're supposed to end at 4, right? Is that right? Yeah. So I think we should probably take this time to thank all of you listeners who have been with us, and really thank thank each one of our panelists. And I really the Latinx Center of Excellence really is appreciative of this collaboration with Wiley Liu and her colleagues from the Center for Community Engagement at UCSF. We would like to continue to be providing these sorts of updates if people find them useful. So if you find it useful and you're a listener, let us know, because we want to know, we want to be sure that folks who work with immigrant populations are themselves feeling that they know where they can ask their questions. We know how important you are as trusted intermediaries. We know how important you are within the community, the different communities you serve. And we want to make sure that you get your questions answered so that you can disseminate truthful and helpful information. So with that, Wiley, I'll turn it over to you. And again, our thanks to the panelists.
Well, Elisa, you said everything already. So thank you, everybody. Again, the panelists, you're fabulous, very insightful. I want to thank Alicia's team member, Alana Feitinger, and also Julia Farfan, who did all the heavy lifting behind the scenes. So thank you, everybody. As Dr. Fernandez said, if there are topics that you're eager to hear more about, please let us know. This is the 3rd webinar that we've done. People have already told us they want to hear more about other issue areas. So do let us know, and we look forward to producing more of these webinars for you in the future. So thank you, everybody. Stay healthy, stay safe.
Thank you.
Thank you all.
Thank you.
Thank you.
Thank you.
Thank you.